Greetings, this is Moanika Paul Stephen, a student of Master's Computer Science at Victoria University, here to present my research proposal titled Evaluating Effectiveness of mTrac System in Reporting Emergency Obstetric Outcomes at Vusede Health Center 4 in Jinja District. This presentation covers Chapter 1, Chapter 2, and Chapter 3 of my proposal. The background of this study has four perspectives: historical, theoretical, conceptual, and contextual. Historically, incomplete maternal death reporting has been a problem since the 1980s, and Africa accounts for 66% of the global maternal death, yet only 36% are captured. Mobile health systems like the mTrac systems were introduced to solve this problem, but Uganda still reports below 50% of the maternal death at the health centers 3 and 4 levels. At Vusede Health Center 4, facility registers show 5 to 8 maternal deaths per year, but mTrac records only 2 to 3 maternal deaths, which gives a reporting gap of 60 to 70%, and the facility has been low performing for the past 3 consecutive years. No prior study has examined the relationship between the emergency reporting process and the mTrac effectiveness at this specific facility. Ideally, mTrac should capture 100% of the maternal death, but in reality, only 30 to 40% are reported. The facility registers show 5 to 8 death reports per year, yet mTrac records only 2 to 3. The consequences are severe. The Ministry of Health operates with incomplete data, leading to inaccurate statistics and misallocated resources. Healthy workers receive no feedback, which reduces their motivation, and unreported deaths remain invisible to policymakers, which costs people's lives. Therefore, the purpose of this study is to evaluate mTrac effectiveness by examining the relationship between the emergency reporting process, which is my independent variable, and the mTrac system effectiveness, which is my dependent variable. The study has 4 research objectives. The first objective is to determine the estimated true number of maternal deaths using facility registers, community reports, and hospital records. The second research objective is to assess mTrac effectiveness by comparing true death against mTrac reported death. The third objective is to examine the relationship between the emergency reporting process, which is my IV, and the mTrac effectiveness, which is my DV. The fourth objective is to identify the extraneous variables that moderate this relationship, and the extraneous variables include supervision, training, accountability, motivation, network, and airtime availability. The scope is limited to Busede Health Center 4 and its 15 catchment villages, covering a 5-year period from January 2021 to December 2025. The content focuses on the 5 elements of the independent variables, the 3 elements of the dependent variables, and the 6 moderators. The significance of this study is both academic and practical. Academically, it provides new evidence on how the emergency reporting process affects the mTrac effectiveness at the Health Center for facility. It fills a knowledge gap identified by Namubiru and colleagues in 2021. And practically, the findings will inform the Ministry of Health and the Jinja District Health Office about the specific barriers of the facility. I will articulate 5 authors that pin my study. And the first author is Yusuf and the colleagues in 2008, who adapted the Health Information System Success Model, which is my primary theoretical framework. It provides the 6 dimensions for evaluating health information systems. The second author is Chiberu and colleagues in 2017, who studied the mTrac barriers in eastern Uganda. They found that while 85% of health workers knew how to report, only 52% did so consistently and effectively. The third author is Namubiru and colleagues in 2021. These ones assessed the mTrac data quality in Jinja district. They found that mTrac captured only 37% of the estimated true maternal death, which directly supports my study. The fourth author is Guchoya in 2019, who examined the health information system effectiveness in Kenya and found that timeliness and completeness significantly predicted the system performance. The fifth author is the World Health Organization in 2016, which established the 100% reporting standard under maternal death surveillance, which defines my dependent variable measurements. For research design, I am using a convergent parallel mixed methods design. The quantitative component is non-experimental, descriptive, and correlational, which means I will count death and calculate the reporting gap. The qualitative component uses semi-structured interviews and focus groups to explore why gaps exist. The study population includes approximately 112 individuals using the Yamane formula. My sample size is 82 participants. 82 participants, which will involve 12 health workers, 30 village health teams, and of which each village will contribute to VHT, 10 traditional birth attendants, the TBAs, 44 women who experienced pregnancy loss, and they will be reached through snowball sampling. 5 district health officers, which will make a total of 82 participants. I will use both secondary and primary data collection methods. Secondary data comes from document review of maternal death registers, referral registers, VHT monthly reports, and the mTrac central database from the Ministry of Health. Primary data comes from 5 instruments, and the first one is document review forms to extract death records. The second instrument is the semi-structured interview guide with 12 open-ended questions. The third instrument is the focus group discussion guides for VHTs. The fourth instrument is a structured questionnaire using a 5-point Likert scale to measure barriers like lack of airtime and poor network. The fifth instrument is a network coverage assessment form to measure actual MTN and Airtel signal strength at different times of day. For data analysis, quantitative data will be analyzed using descriptive statistics. The reporting gap will be calculated using the formula estimated true death minus mTrac reported death divided by estimated true death multiplied by 100. I will also use correlation analysis to examine the IV-DV relationship. Then the qualitative data will be analyzed using the Brown and Clark's 6-phase thematic analysis. The data collection procedure has 7 steps over 8 weeks, and these include obtaining ethical approvals, reviewing registers, obtaining mTrac data, conducting network assessments, administering questionnaires, conducting interviews and focus groups, and finally, transcribing and securing data. Ethically, I will obtain IRB approval and administrative clearance. In summary, the problem is clear. Only 30 to 40% of the maternal deaths at Busede Health Center are reported through mTrac, leaving a 60 to 70% gap. This study focuses on the emergency reporting process as the independent variable and the mTrac system effectiveness as the dependent variable. Using the convergent parallel mixed methods design with 82 participants and 5 data collection instruments, I will triangulate true death, calculate the reporting gap, examine the IV-DV relationship, and identify the moderating variables. The expected outcome is evidence-based recommendations to help close the reporting gap and improve the maternal death surveillance and ultimately save people's lives. Thank you.